So what we're going to do in this session is talk particularly about assessing barriers to knowledge use. So a number of you, when we talked about the examples, are saying you actually want to understand maybe why physicians weren't washing their hands, or what were the kind of specific barriers that might be preventing good care in diabetes care in primary care. And we're going to split this. So I'm going to kick off and just do probably sort of 5 to 10 minutes, and then Justin's going to come after me. And I'm going to largely talk about this from a non sort of theoretical perspective, to sort of hopefully demonstrate the kind of evolution of my thinking. But this is a slide I've used for probably almost 20 years about what are the potential barriers to implementation. And I think one of the issues is that if you went back maybe 20 to 30 years ago, the assumption was that the major barrier was knowledge. The clinicians didn't have the right knowledge, and the major response was just give clinicians better knowledge and the world would be a better place. And I think what this slide highlights is just the recognition that actually there are many things that interfere with good quality care. And so, as I said, this is a sort of non-theoretical aid memoir, but you could have barriers at the structural level. The way we reimburse healthcare professionals. So I think when we're talking about diabetes at the back, there are concerns around sort of an overemphasis on performance measures and pay for performance. But also, when I moved to Canada in 2002, the predominant method of reimbursement for general practitioners was a fee-for-service basis. Now, when I came to the Northeast in 1985, Donald Irvin, at that time the regional postgraduate advisor, said there are 3 things primary care do: acute care, chronic care, and preventive care. And any idiot can do acute care. Well, it's Donald Irvin. He said this. I'm just parroting Donald Irvin. Either the patient's going to get better or they need to go to hospital, and that's probably not a very hard decision. But actually, chronic care and preventive care are really difficult because they require you to think about establishing systems of care and accountabilities to achieve certain aspects of care. And so when I moved to Canada in 2002 and we had a fee-for-service basis, fee-for-service encourages family docs just to fill up their surgery with people with coughs and colds. The good family docs will not. They'll actually think about, okay, well, how do we provide high-quality preventive and chronic care? But I think there's a financial disincentive in the healthcare system about encouraging primary care to think of that more population-based, which was almost second nature, certainly to me in the UK. Some of the other things may be coverage decisions. So Mike Power and I were involved in a project called Afro-Implement, which linked European and implementation research in sub-Saharan Africa in the 1990s. And we had an example there of the professor of obstetrics in Harare, who was one of the trialists who did the definitive trial that showed that magnesium sulfate was the treatment of choice for women with eclampsia around the world. 2 or 3 years after they'd published the trial in the Lancet, he was an author, Kassim couldn't provide magnesium sulfate to women with eclampsia in his hospital. It clearly wasn't a knowledge issue. Clearly wasn't a kind of skill issue because everyone in his hospital knew how to do this. And the issue was at that point in time, the Zimbabwean government chose to buy drugs according to the WHO essential drugs list, and the WHO had not updated the essential drugs list. So this was almost a supranational, global coverage recommendation that impacted on someone who knew the evidence backwards not to provide the best care he could. A few years later, WHO did update their essential drugs list, but that then led to a range of other issues surfacing in Zimbabwe around the supply of the drug chain and the security of that. But the initial barrier was just the Zimbabwean government, quite rightly, many governments are looking to WHO for guidance and then not updating their guidelines. There can be barriers at the organisation level that maybe we may not have the right skill mix. So I'm not sure if this is still current here, but certainly I remember before I left the UK, there's a fair amount of information that would show that general practitioners and practice nurses were not very good at providing good dietary support for patients. If you look at guidelines for diabetes or dyslipidemia, the first 1A recommendation will be actually about optimizing the diet of patients. Given that most of these patients are being handled in primary care, certainly in the late 1990s, early 2000s, I'd argue in the UK, we just didn't have the right skill mix because there weren't enough community dietitians that could provide support to patients who might need that. So that would be a sort of an issue about skill mix. And the last one may be a lack of facilities or equipment. We're doing some work in Canada about diabetic foot care, and one of the simple things is actually just do practices have access to the microfilaments that they need to use if they want to check patient sensation. So really sort of very simple stuff that can get in the way of just providing the care we know. There can be barriers at the peer group level, and the issues here are that human beings are social organisms, and when we work together, we develop a shared set of habits, routines, ways of looking at the world. So when I was a GP trainee and I went from one hospital ward to another hospital ward, they'd do things completely differently. And no one said, well, that's because Newcastle General is very evidence-based and RVI is not in any way evidence-based. It was just that sort of, basically microcultures emerge. And when we're working in social groups, it's very hard for us to change our own behaviors if the social group expects us to behave in a different way. And so under those circumstances, we often have to think about challenging the group about changing their behavior. There can be barriers at the individual healthcare professional level, which may relate to knowledge, attitudes, or skills. What we've found is that from a knowledge perspective, for many areas where healthcare systems are failing to deliver the quality of care we want, healthcare professionals often have good enough knowledge. We may not know the latest lipid level guidance or target from NICE, but actually we're probably failing to deliver care to the standard of the previous lipid target. So having a generic rule about aggressive cardiovascular risk management in diabetes may be sufficient. So we may not have perfect knowledge, but it's often good enough. One of the things we are finding, though, is often is kind of procedural knowledge that may get in the way. Well, how do we organize this over here? Paul Gorman, who's a US family physician, spent some time in the UK where he just followed GPs. And he said it's very rare that they came up with a clinical technical question, but often the issues where they had knowledge gaps were actually about how do I do this in the system? How do I actually achieve this and help the patient find the way around the system? One of the other, but I think we are not very good at sort of thinking about what are the skills that healthcare professionals need to have. Colleague has a brother who flies Boeing 737s. Boeing make a minor change to 737s, and people come in and have a sort of fairly intensive 2 or 3 day training. Pilots, thankfully, as someone who will fly very soon, and what that means for them. We introduce changes all the time with healthcare professionals and somehow anticipate that they naturally will be able to take on whatever it is without thinking about what the skill base is. It would be a bit like if Usain Bolt's trainer said, really, we did really well at the last Olympics. Now what you should do is just rest up for the next 4 years and turn up at the next Olympic and just race once. And we were often asking healthcare professionals, practice is something we do all the time, but we somehow anticipate that sort of healthcare professionals don't need to practice what they do. And there are problems at the kind of the professional-patient interaction. This relates to really what, or more the kind of cognitive psychology end of this. But there's a number of sort of issues about how the human brain is put together that imposes limitations and workarounds in our lives. So one of the issues are, if you listen to people talking about things like continuing professional education, the highest state of nirvana we should reach is a reflective practitioner. But one of the issues is the way we get through life is by not being reflective, okay? And that applies to our personal lives. So we often, we have lots of habits and routines that we use because they work for us. So when you get up in the morning, you don't sort of think, or when you wake up in the morning, you don't think, should I get out of bed or not? Which side of the bed should I get out of? Where's that bathroom place? I wonder whether there's any toothpaste. We just, particularly before coffee, you kind of just do stuff. And these habits and routines help us get through the day. And it's exactly the same in our professional lives. Okay, so when I have crushing chest pain and go into the Freeman Emerge, I don't want the Emerge doctor physician to sit there and think, crushing chest pain, what's the differential diagnosis for that? What do I have to do? I want the emergency doctors to respond. And that's what clinicians do. 95% of the time, we have routines and habits that just let us get through the day. And often, what we're trying to do is sort of understand that when do I have to kick out of that routine? When is something different, that this doesn't sound like a typical MI type chest pain? I also want to check that they've not got a dissecting aortic aneurysm or something else. So human beings get through the day in our personal lives and our professional lives by having habits or routines. It's really hard to change a habit and routine, though, in real time, okay? And the classic description of that is think about driving home in the evening, and you get in the car and you get out of the car at home and you really can't remember where you've been, where you've driven. Think about then, you sort of drive home and you've got, and there's an accident and it's in an area which you don't know well and it's not clear that your kind of normal ways of working around will work for you. You suddenly have to kick from an automatic into a reflective process, and that's really hard to do. And it's a lot more challenging, and your brain starts to kind of hurt. So it's the same for professional lives, but it means that 95% of care that is driven by these sort of fairly semi-automatic behaviors that are really hard to change. We also use scripts. So I've not seen a patient probably for 20 years now, but I can turn on my script about why you don't need an antibiotic for your sore throat. Because I'd get to the point in time in a consultation, decided the patient didn't need an antibiotic, and I'd turn this on, and I could go blah, 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 and I wasn't thinking about what I was saying, but it allowed me to think, what else do I have to do with this patient? Or I'm running late, how I'm going to catch up, or who's going to pick up the kids, or whatever. So it allowed me to have a sort of space where I didn't have to think in the same way. And again, scripts are really powerful tools, but they're really hard to change. So we did some work about trying to improve family practitioners' advice to stay active in low back pain in Australia. And one of the key issues was just getting people to re-engineer their scripts so they felt comfortable about sort of thinking about how to actually talk about that tailored to the individual patient. So these are kind of limitations that we have as human beings. It makes our lives gloriously messy, but they apply to our professional lives. The other issue is that we have what cognitive psychologists call bounded rationality. We don't have supercomputer brains. So we have maybe 486 architecture brains. And people remember that if you basically stress your computer too much, you get the blue screen of death. Exactly the same with our human brains. If we ask human beings to do complex decision-making in time-pressured, chaotic settings, they'll make mistakes. Clinical care is always delivered in chaotic, time-pressured settings. So we should anticipate that there's always going to be likely acts of omission just as part of the chaos of the healthcare system that we've got. So hopefully you've got the idea that there's actually lots of different barriers. And we probably, if we go back to that idea about understanding what's driving the behaviors, need to sort of think about how do we best surface that, because it may be there are different things you need to do if you're trying to change someone's habit to changing someone's skill or changing the sort of social norms in the peer group. So a better understanding of the barriers may allow us to start to sort of think about what interventions might be useful. One of the things that we're particularly sort of moving to is starting to, or the work we'll talk about is starting to think about this from a behavioural perspective. So, for the last probably 15 to 20 years, I've thought we're really trying to change behaviours in complex systems. But the value of thinking about this from a behavioural perspective is it opens up 100 years of modern psychology. It opens up 50 years of sociology and organisational sciences. And it suddenly enriches our toolkits and our levels of understanding. Okay? And so what we're largely going to do is then talk about some of the models in this session that are coming out of psychology that may help you to think about this in slightly different ways. So behavioural approaches may allow us to make a diagnosis, think about who needs to do what differently and what is preventing them to do so, and also may identify lever points for interventions to try and improve the quality of care. Again, this is my, I'll give you kind of the psychology view of this, but this is a series of questions I've used when people brought up or brought quality problems to me. What is the behaviour or series of linked behaviours you're trying to change? Who performs the behaviours? When and where do they perform them? Are there obvious spectral barriers? And is the behaviour usually performed in stressful circumstances? And my answer for the last one normally is yes, but it's useful to have there to remind myself that just the chaos of healthcare setting is a barrier. The value of this that I've found is that people often will define their quality problems in rather abstract terms, and it makes it really quite hard to get traction on them. And getting people to really think about what it is you think you should change, I think helps just make them start to think in a much more practical way. And as an example, in the 1990s, I visited the Royal Women's Hospital in Melbourne, in Australia, and they said our biggest quality problem is increasing active third stage of labour. So this is once the baby's been delivered, the placenta's been delivered, giving an injection to the mother that will constrict the blood vessels in her uterus that reduces the risk of a postpartum hemorrhage. And they said, we've been trying to do lots of things and we really can't get traction. So I asked these questions: what is the behavioural series of behaviour you're trying to change? Someone has to recognise the placenta's been delivered, someone has to give an injection. Who performs the behaviour as well? Australia has a midwifery model, like the UK. So there's a midwife that's largely been there throughout the labour with the woman and is at the kind of catching the baby end. And there's another midwife that comes in sort of during the second stage when the woman's pushing and provide additional support. Once the baby's been delivered, the midwife who's been there throughout the pregnancy, throughout the labour, will catch the placenta. And then the sort of second midwife will often sort of basically help tidy up, clear up, and eventually probably leave and go and have a cup of tea or whatever. So it became it started to get people to think about, well, who should recognise the placenta's been delivered? Well, maybe it's a kind of midwife that's catching the placenta. Who should give the injection? Well, not the kind of midwife who's catching the placenta, because normally immediately after the baby's delivered, that midwife will do an awful lot about kind of helping the mother bond with the baby, trying to encourage things about breastfeeding or other things, kind of strong social support of the mother. So you wouldn't want the midwife then to sort of say, well, just hold on a sec, I'm going to come over here and inject you. But you have another midwife who could actually probably do that relatively easily before they left the room. In the UK, this didn't seem to be a big problem, certainly when I was practicing in South Shields. But it started to make it a much more tractable issue. And the midwives in the group started to get more excited because actually, okay, well, we can actually solve this. So instead of having a rather abstract, this is about actually third stage of labour, it's about, there's a couple of clinical processes that we need to change, and there's probably relatively straightforward ways of doing it. There's a whole range of other issues in Australia about whether this is part of natural childbirth or not, but it actually helped really ground people. So if you came to me and said, we want to try and improve physician hand hygiene, I'd start with something like this, or we want to improve diabetes care. Just tell me what it is you want to change. What would be different if we were successful than if we're not now? What happens now, and how do we move that forward? This is a different way that particularly psychologists would argue, which is about just trying to get your specify the target behaviours in terms of the act of performing the behaviour, the action being performed, the target in which the action is directed, the context in which the action is performed, and the time during which the action is performed. So you could use my kind of formulation of active third stage of labour into this very easily. But the idea here is it just is trying to give you clarity about what to change. Because otherwise you kind of have this sort of rather abstract view about we're trying to improve management of cardiovascular risk factors in diabetes care. Well, what does that actually mean? Who's going to have to do what differently if we want to make sense of this? We're going to talk a lot about potentially the value of theory to do this. And sometimes when I talk to some healthcare audiences, I mention theory. There's a nasty smell in the room. There's a kind of real, people aren't very happy with theory. And that's because there are two ways of looking at theory. One is, well, that's just theoretical. There's no semblance whatsoever to the real world. Or the other is actually a theory is a empirically derived and validated set of principles about how the world works. And we're interested in theory in terms of those generalizable principles where we have an empirically validated view about how the world works. Not, I woke up today and had a great idea that's completely my own and bears no semblance whatsoever to how the world is. Okay? So a theory is an organized, heuristic, coherent and systematic articulation of a set of statements related to significant questions that are communicated in a meaningful whole. This is very long. for the purpose of providing a generalizable format of understanding. But it describes observations. Good theories are based on observations that have been repeated and say, actually, this is the way the world works. It summarizes the current evidence, and it can propose explanations and yield testable hypotheses. So we would argue that, if there are well-validated, robust theories from any sector which may be helpful for us thinking about how we change behaviors in complex systems, we should use them. Because they're kind of often, it's a shortcut to 50 to 100 years of thinking. And the hope is that interventions are more likely to be effective if they target determinants of behavior. Theoretical frameworks facilitate accumulation and integration of evidence across the context of population behavior of the effects and causal mechanisms. When I put my list of barriers up, I have colleagues like Richard Grohl or Andy Oxman. If they'd have put their set of barriers up, they'd have been different. We often have personal languages or personal ways of viewing the world, but that then gets in the way of communicating. Within theory, where you're trying to sort of codify or sort of say, okay, here's kind of key constructs, you're starting to give a language that we can talk together. So if Justin talks about beliefs about consequences, I know what he's thinking about or what he's talking about. So theory is useful from that perspective for helping communicate. And increasingly, what theory can do is start to give us thinking or start to think about why and under what circumstances certain interventions might be effective. Ewan Fairley and Steve Shortell suggested 4 levels of intervention to improve quality of care, and these just map back to my barriers. They could, you could improve quality of care by focusing on the individual health professional, on the healthcare group or team, the organisation, the larger healthcare system. And depending on the barriers, you might do different things. But different types of theory would be relevant to interventions at different levels. So if you're looking at the larger healthcare system, political or economic theory might be helpful for thinking about understanding the determinants or drivers in that area. If you're looking at organizations providing healthcare, you've got organizational psychology, but also business and management sciences. Healthcare groups or teams, sociology, anthropology, social psychology, individual healthcare professional, health psychology, and the cognitive psychology perspectives. So this highlights actually some of the challenges if you're trying to make sense of the world, because very few people have, I don't think anyone has all of those theories at their disposal. And it does mean that actually what we need to do is find ways in which we can engage people who may have that set of expertise that might be useful as we move this forward. What we're going to talk about today is largely theories that will operate at this level, and that's at least in part because often the care that patients get is directly driven by what the individual health professional does or what their team does. And so even if we change the remuneration system, it's largely going to be mediated through what happens when the individual healthcare professional is there. So we're going to look largely at these areas. It's not to devalue these, but there are other people who are also sort of trying to look at some of these areas. One of the challenges if you want to use theories is that there's too many of them. There are many theories and frameworks of individual and organizational behavior change, and they're often conceptually overlapping. And they often use different language to largely say the same thing. So in social cognition theory, which is one of the major theories in health psychology, Bandura will talk about self-efficacy. In the theory of planned behavior, Eisen will talk about perceived behavioral control. Now, I'm sure at a kind of psychologist, high rarefied theoretical level, there are important differences. But for most people trying to use the theory, it's actually they're very similar, and it's very, very hard to separate them out. So one of the challenges if you're a non-psychologist trying to use this area is how do you make sense of these different theories? And what Justin's going to do is describe 2 recent attempts that have been trying to make theory more accessible. So you don't have to be a PhD psychologist to start to use these bodies of knowledge, hopefully if you get a sense about what these models are. So Justin.
Thank you. Right, so as Jeremy was saying, if any of you have thought about using theory, you probably came across the realization that there are just so many different possible theories that you could use. And that's something that was recognized within the applied psychology literature as well, and particularly spearheaded by work led from UCL by Susan Mickey. Started to think about how can we start to synthesize the range of different theories that are out there that we've demonstrated to be related or to explain behavior and behavior change into a more coherent set of more generalizable principles or domains that can be more helpful for those who may not necessarily have a background in psychology per se. So the first framework that I'm going to cover today that we're covering is the Theoretical Domains Framework, or TDF for short. And this is just the most recent publication reflecting the development of that, and it's published in Implementation Science, which is an open access journal, so if you want to have a look at the details, you can. But effectively what Susan and her group did, they brought together a group of not only psychologists, but also health services researchers into basically a room and got them to think of and identify what are the top predominant evidence-based psychological theories for understanding behavior and behavior change. And they identified 33, of which within those theories, there were 128 explanatory constructs. Clearly, a massive amount of potential constructs here, and if you were to go into this literature and say, well, which one should I choose, there'd be no real indication potentially on which one to go for. So what they did was they spent a lot of time looking for commonalities between these different explanatory constructs and essentially synthesized those into 14 different domains that largely cover what is currently known based on decades of behavioral science research about the factors that influence behavior and behavior change. So when we go, and the nice thing there is that it provides that overarching holistic perspective on the range of different factors that are related, so that if you go into a room, as Jeremy was saying, that you have one person that might think of some factors, some other people might think of other factors. What this framework provides is really that comprehensive approach of all or most of the key factors that we know influence behavior change. So what I'll do for the next few minutes is actually to walk you through the 14 different domains. First of all, because your task is going to involve actually using this, but also just to highlight how some of these may be familiar to you, some of them may be less familiar to you, but it can actually provide us with a shared language so that we can, when you say you're talking about knowledge, I understand what you mean. When we're talking about goals and intentions, we all have a shared understanding. And it also provides a basis or a framework for starting to diagnose barriers, starting to look at if you were trying to change some sort of behavior in a hospital setting or a primary care setting, trying to change a clinical behavior, you could go into a practice and try to diagnose the problem. Go in, do interviews, trying to talking to clinicians about the different factors within this framework. And what we found is when we do this, we relatively quickly, within 10 to 15 interviews, quickly get a data saturation. So we get a sense of what are the real barriers linked to each one of these domains. So the first few won't surprise you, and when you did the first task, some of you mentioned this. Clearly, one of the key fundamental drivers of whether we do something, whether we change what we do, are knowledge and skill. So if you were to go into a practice and ask people, or ask clinicians, is there the fundamental knowledge there? Are they aware of the evidence base and the guidelines to begin with? And is that a barrier that needs to be solved? And also, clearly, the skills level. Is there sufficient training in the techniques that are required? Often what we find, particularly in the area of diabetes care where I work, these sort of things tend to be well known. People know how to prescribe, people know how to give types of advice, they have different scripts, and they know the knowledge, they know the evidence base, typically. But that might not always be the case in different settings. The next possible domain, or the next domain within the framework, is this idea of social or professional role and identity. So it's the idea that is this action that we're looking at, is it part of what is typical for a profession? Is it a kind of stereotypical thing that a GP does? Or is it something very different from that? And that might be a barrier to people actually changing. If they don't see it as part of their professional role or their identity, then that may be a barrier that's irrespective of knowing whether they should, what the guidelines say. A really fundamental domain, which is persistent in a lot of different theories and is linked to a lot of different techniques for changing people's behavior, is this idea of beliefs about capabilities. And one way to describe that is, getting a sense of people's level of confidence that they have the capacity to actually do the behavior, which kind of seems self-evident that, typically clinicians may, should be relatively confident in what they do, but it's not just this general feeling of confidence. It's actually, are you confident that you can prescribe according to the guidelines even when barriers come up? Do you feel that sense of resilience or self-efficacy to be able to do the behavior even when challenges emerge? And often this tends to, we find that this in particular is one of the domains that tends to come up relatively frequently. Another more general domain is this idea of just general optimism. Do you think that doing this behavior in the grand scheme of things is actually going to make a difference? If you don't have that optimistic perspective, potentially that may impede on doing the behavior. Beliefs about consequences, or otherwise known as attitudes, is really do you know the pros and cons, the benefits and the negative aspects of doing the behavior? And some of those beliefs may be well-founded, some of them may be wrong and need to be corrected, but just getting a sense of the typical, what you might expect, what happens if you do the behavior. Reinforcement is an interesting one. It's based on learning theory and work by Skinner many decades ago. And this is a different usage of the term reinforcement here. This is specifically rewarding or incentivizing behavior so that when you do the behavior, you actually are rewarded, and there's that contingency between, if I do this, I get this. So this is where all of the discussion around incentivization and financial rewards would fit in. Is there a reinforcement structure that supports the behavior or not, and is that a barrier to performing the behavior, which may be something to look for when diagnosing a problem in a particular area. Another fundamental construct or domain is just the general idea of intention. Clearly, people need to be motivated in order to perform a behavior, and just getting a sense of how motivated clinicians are, or service providers or managers or whoever you're interviewing, or patients. What's their initial level of motivation? The work that we've done and that Jeremy's done tends to find, particularly in clinicians in primary care, clinicians tend to be motivated to provide good quality care. That almost stands to reason. So it tends to be less about trying to get clinicians motivated and more to do with how do you translate that good motivation into action. Related but slightly different, and recognizing that it isn't just about one particular behavior that clinicians do. Clearly, particularly in primary care, but in many other settings, people manage many different competing demands. So one of the things you may want to get a sense of is how much of a priority is this behavior you're trying to change relative to the range of other things that people do. If it's a low priority, you may well have the skills, the knowledge, the beliefs about consequences. You may feel very confident, but if it's a low priority, why would you change? And so there may be a reason to focus on that as a particular barrier, irrespective of all the others. The next one comes mainly from the more cognitive psychology side of things, and this is just the very straightforward, do people ever forget to do it? Are there reminder systems in place? What are the memory decision processes that drive this behavior, and could that be a barrier? Is it just that clinicians are pressed for time and they may forget certain things and need to be supported in that way? A big one that sort of recognizes that it isn't all about the individual necessarily. It is recognized, this framework does recognize that behavior occurs within a social and physical environmental context. And so really getting a sense of, are there sufficient resources at those levels to support the behavior? And if not, what's missing or what's in short supply? Are the barriers at that level? The framework certainly recognizes that as well. And in relation to that also, what are the social influences? Who has a say in whether the behavior is performed? Who influences the actual person? So the clinician may feel that they're influenced by their peers, by national organizations and guidelines. There may be a range of social influences that are maintaining a particular behavior, or that may influence the performance of a new behavior that need to be explored when trying to diagnose what the barriers might be in a particular situation. One that tends to be, when I present this to clinicians, the kind of emotion side of things tends not to be seen as necessarily a driver of clinicians' behavior, but it isn't just the kind of general emotions. It's things like, does a certain behavior cause stress? Does it cause anxiety? And does that actually lead you to not perform it or not want to perform it? So at least diagnosing that, having a sense of, is this an important issue that may be needed to be tackled when trying to change behavior is worth covering. And finally, behavior regulation, which is a more general way of describing what do people actually do to make sure that they perform their behavior. Do they have reminders in place? Do they self-monitor what they do? Is there an audit system to provide them with up-to-date information about what they're doing, providing them feedback? A range of different things that we can do to support whether we perform this particular behavior. And so these 14 domains, in a rather large nutshell, can provide you with a in a sense, a topic guide, or the start of a topic guide that you could go into any setting, speak to the people there on the ground, and actually start to get a sense of what are the potential barriers in your organization in the behavior, in relation to the behavior you're trying to change, and actually categorize them, provide you with a set of categories that you can use as a basis. So it isn't just going in and hopefully identifying some of these. It provides a more comprehensive approach to doing that. So that's the TDF, which really is a framework for understanding barriers and facilitators for a particular behavior. The second one, which I'm not going into detail right this moment because we'll be covering it in more detail later, but it's just to highlight that what the TDF provides is an outline for, or framework for understanding barriers and facilitators, but it doesn't necessarily tell you how to change those barriers, but it does provide that first step. And that's really where the behavior change wheel as a framework comes into play. And we'll get into that in more detail, as I say later. And for those of you who may have attended an AHSN stakeholder group meeting, I think in February, Paula and I did a taster session on the behavior change wheel. So today we'll go into that in a lot more detail. And for those of you who are there, hopefully it'll be a chance to upskill a little bit more on using this. And for those of you who haven't had a chance to see it, hopefully it'll provide you some new insights. So I won't go into too much detail, only to say that this is linked to the TDF, and how it's linked is this central component, this middle portion, the green portion around capability, opportunity, and motivation. These are three fundamental aspects of whether we can perform a behavior or not. And those are all linked to, can be linked back to the TDF. And the way that we can do that is, and this is another way to reflect that. So that middle spoke, that middle hub of the wheel suggests and is summarizing is, it's a kind of higher level summary of the TDF. It's saying people need to feel capable, either have the physical ability or the psychological knowledge to do it. They need to have that conscious, reflective motivation that Jeremy was talking about, but also that more automatic, it recognizes that automatic aspect of people's behavior. And finally, people need to have the physical and social, environmental opportunities to do the behavior. And how that's actually linked to the TDF is what Susan, Mickey, and her group at UCL have done is actually mapped all of those 14 domains that I just talked about onto each one of these three. So effectively what you could do is decide on whether to take a very fine-grained approach to understanding barriers at the TDF level, and that could be aggregated up to the COM-B, or you could even just start at the COM-B level and looking into a particular setting. Is this an issue of people's capability? Is it an issue about people's motivation? Is it an issue of opportunity? And the answer to that question will help you to be more selective in the approach that you decide on for intervening, because not all intervention strategies would necessarily be helpful in promoting each one of these, or addressing each one of these barriers, and that's something that we'll talk about a little bit later. So you might be asking yourself the question, if this may be a useful framework for your own work or for your own setting. So should you choose the TDF or should you choose the COM-B? And really, they're related to each other. So the COM-B model highlights those higher level factors. The TDF provides a finer grain analysis that can ultimately be aggregated up. But I think it doesn't so much matter which one you choose or which level of granularity that you take. But it's more to make the more general point here that what theory and theoretical frameworks, and this one in particular provides, is it gives us this common language so we can start to build a cumulative knowledge base to start to learn from past successes, start to learn from past failures, start to learn from what are the common barriers across settings, what are particular barriers in particular settings, and using the same language so that we know what we're talking about when we say role, social role, and identity. We know what we're talking about when we say behavioral regulation. And so we can start moving away from trial and error and one-off approaches to looking at barriers and facilitators to actually use the same sort of framework to understand those so we can learn from each other and avoid going down it seemed like a good idea at the time route by failing to identify certain barriers that may well have been there. And really, I think the real strength of the framework, of taking a frameworked approach to barrier identification, is that it gives you this opportunity for designing more targeted interventions that are optimized to focus specifically on addressing the barriers that you identify, so that certain types of interventions around incentivization or punishment might be helpful for certain types of barriers, but maybe not all types of barriers. And so identifying what barriers are in place will help you hopefully to identify what are the best strategies suited to address those barriers. And that change aspect is something we'll cover a little bit later.
Given we have a bit of time, I just wonder whether anyone had any kind of questions on this, because I think in the first section probably there wasn't a lot of new information. I suspect in this one there's a bit more information. So if anyone have any questions, if not, it's fine because we can carry on. But okay, so I can see that Michael Power has his hand up.
Yes.
And you need to use a mic.
The TDF seems to have very strong face validity. Is there any evidence to support its use? And so that's one question. And the other one is, I'm just curious as to why it seems to ignore the findings from behavioral economics started by Daniel Kahneman and Amos Tversky. It doesn't seem to take their discoveries into account.
So the answer to the first question is it based on any evidence? And so if we go back to this, well, essentially the 33 theories on which they're based on are, by definition, they're chosen as theories that have an evidence base. So it isn't that they're theoretical or hypothetical, it's that they're reflecting an empirical test of whether these theories explain behavior or behavior change. The question of whether it's been applied in a particular organizational setting or a healthcare setting is different. I think it may well be that some of the evidence base is applied in different populations, and really I think for me anyway, the interesting thing is actually applying them in new contexts such as in healthcare settings. So some of the theories that are involved here may have been used more or less within clinical practice settings, but over the past, since the development of the TDF, there's been a wealth of evidence to show that these theories apply to any types of behavior, because ultimately behavior is behavior, whether you're talking about clinical behaviors or patient behaviors. The same factors seem to drive people's behavior, and we're developing an evidence base to show that's indeed the case. Does that answer your first question?
We've used TDF now for probably about 10 or 12 different behaviors across a broad range of healthcare professionals and settings. So from delivery suite nurses in terms of their use of electronic fetal monitoring, chiropractors in both Canada and US in terms of their use of x-rays, anaesthetists and surgeons around preoperative testing. And one of the things that we've done is, first of all, we found that it's pretty flexible. It does actually it's relatively easy to apply across these broad range of behaviors, and it services different issues. So I think one of the tests is, if everything came back as being, it's a knowledge issue, then I don't think it'd be helpful, but it does surface different, the things that are driving, say, the delivery room nurses' behaviors are very different to the things that are driving the anaesthetist behaviors. And so I think the fact that you get different sort of views of them are useful. And when we've reflected these back then to the kind of clinical groups, they've also thought that the results of these are often or have a lot of face validity, even at some points in time in a rather depressing way. So I'll talk about the hand hygiene, where we surfaced a number of issues that the hand hygiene leads in the hospital were aware or hoped had gone away, and the TDF brought back up. So I think where we need to get to is we need to do the TDF, we need to then develop interventions based on that and test those formally. But I think there's a lot of evidence suggesting it's at least a useful tool because of the kind of comprehensiveness and actually the ease of use.
And really the evidence base comes from the underlying theories that inform the TDF. But going to your question about the sort of whether it incorporates work from Kahneman and the bounded rationality type of things and cognitive biases, I guess that sort of highlights the tension between trying to develop a framework that is at a high enough level to sort of have these broad categories, but at that you then start to lose some of the detail. But that aspect would fit under this memory, attention, particularly decision processes. If you go into the actual papers, it actually highlights the particular types of cognitive biases would be addressed within this. And for the sake of brevity, I haven't really highlighted that, but it does definitely recognize those decision-making processes as an important factor to consider within understanding people's behavior, definitely.
Okay, one there, and then at the back as well.
Just a quick question. Do you think that the reliance on the behavioural theories is concentrating too much on the level of the individual and ignoring some of the structural and organisational issues or even political and policy issues that need to be tackled?
Yeah, good question. So I think what I would suggest, so there's probably two answers to that. First is the individual behavior may not necessarily only be the clinician. It could be the manager, it could be the policymaker's behavior. So if you could understand those higher levels as people still need to do something different. The policymaker, the guideline developer needs to change what they're doing in order for it to filter down. So you could, I don't think it's ever necessarily gone all the way up to that level, but you could consider that because these factors would apply to those people as well, you could look at behavior at those higher levels, and I think that would be an exciting application of the TDF as well. Whether it sufficiently considers the other level. So if you did take an individual level clinician behavior, does it incorporate those higher level policy factors? And so it does focus, I definitely agree with you, it focuses quite a lot on the individual factors primarily, but it does acknowledge the environmental context and resources as the kind of descriptor for those other levels, though you could go into that in a lot more detail as well. But ultimately those are supporting people's behavior rather than necessarily, the idea is that those policy level factors ultimately would be mediated through, it would change people's knowledge, skills, beliefs about consequences rather than directly driving their behavior per se. But what we will do later today is when we look at the behavior change wheel that framework in particular highlights the role for those higher level features, in particular policy level drivers and how they influence right down to this TDF level.
Yep. I mean, interesting, both kind of Mike and then your commentary. When I talk about this, I say the two domains that are, I think, sort of rather inadequate are the kind of the memory retention decision-making process, because it puts all of cognitive psychology there, and then the external environment, because it's, that's what's capturing, I think, all these other things that particularly you're raising. And I think what it highlights is we need to do similar work that will allow us to make sense of those organizational theories and think about, do they help us in, do they help us to understand this better? So I almost see we need a call out that would say, okay, over time we're going to develop this over here, but it can illuminate this issue. So I talked about a study where we're interested in, there's a significant variation in use of routine perioperative tests in low-risk surgery in Ontario. And so we interviewed a range of anaesthetists and surgeons, and one of the things that came out was a lack of clarity about who has responsibility from an organizational perspective for ordering or non-ordering, and the local sort of processes that actually impact upon that. So if you're in a perioperative assessment unit and the nurse orders the tests before the anaesthetist sees the patient, then it wouldn't, the anaesthetist sort of says, I can't do anything. And so it started to highlight sort of a number of things that you might say would be organizational, and I think the solution was probably organizational, even though we were kind of asking the individual about their reflections. So I think this is a good starting point, but I think if you're doing this, and particularly from those areas where you really were worried about the external sort of context or those broader issues, you could easily add to that without too much of a problem, or kind of just ask or probe more in those sort of areas.
Thank you. I think that this question probably follows on from the last one in terms of how to apply it. Are you thinking of this at a team level assessment, or at a individual action taken at one particular moment of time, or at a trust level?
It could be either, and I've seen people apply this either at team behavior change level or individual behavior change level. It can be applied to. It's more about defining what is the behavior or behaviors that you want to change in what context, and then using this as a framework for understanding what are the barriers and facilitators at that level. So it could be, in some contexts, going to the individual level is most useful. Other contexts may be higher level, team level may be also more appropriate.
But no higher than that? You wouldn't take this at a trust level, for example, assessment of knowledge or skills?
You could do it at a trust level, but you would sort of need to identify what the behavior is that at the trust level that you're trying to understand. So ultimately, you're asking people about what they do, and so the knowledge, the behavior may be different depending on who you're speaking to as you go at the higher level, but it's still asking about their knowledge around what they're doing.
But we've also done this, say, at a provincial level or regional level. So I think one of the issues is where do you want to try and develop an intervention to try and improve things. So it could be that across the academic health science network, you say, we want to think about all the ways in which we can develop much more of across a population of primary care trusts or the population of hospitals, all the supports that we can put in place that would be useful. Or you could say we're really going to focus within our individual trust or organization. So I think to some extent it depends on the kind of behavior, but also where you want to lever. Because I think one of the issues when we talk about kind of quality is thinking about the kind of economy of scale. There may be some things which are much better to situate, say, at the academic health science network level that will support lots of people, rather than sort of saying we want every trust to develop their own issue. So I think to some extent I'd reflect back and think about what is it you're trying to achieve, what behaviours you're trying to change, and at what level do you think your change process might occur. Because it could be you can get 80% of the way there across a population by doing something relatively straightforward across the whole population of trusts, than saying each trust has to really get into this locally. So, we haven't talked about that, so I'm just kind of looking to see whether I said anything stupid to Justin.
And I think, the other strength of this framework is, and I think why it focuses a lot on some of the more individual factors, is that each one of these can be linked to specific techniques that have also been demonstrated to change these factors. So I think that's where when you start to get into environmental level, organizational level theories, there's less of an evidence base from a sort of randomized trial perspective on whether or not those techniques at those levels are effective. Whereas there's a lot more evidence to support change, whether certain techniques are effective in changing some of these other factors, which is, I think, why there's a focus on that level of granularity at the individual level. But again, we'll get into the details of those techniques a little bit later. So if you take the handout that we gave you, I think the second sheet, the worksheets, really we want you to do a similar process. You can choose the same scenario or switch if you want. And in pairs again, what we'd like you to do is to first of all think about what is the behavior or set of behaviors that you want to change, and try to think about that in terms of the behavior itself, so the action, who are the people, the person or the people that you're wanting to change, what is the target, so for instance, if you're talking about a clinician, for example, what's the patient population that is receiving this behavior that the clinician is performing, what's the context in which this behavior is performed, and when is it performed? And once you have an idea, really, of this definition of the behavior that you're trying to change, we'd like you to, using the worksheets, either choose the TDF if you're feeling brave, or the COM-B level, to just try to think about if you were to try to diagnose the issue, try to diagnose the problem of whether or not people can change that behavior. What do you think are the sort of issues that would come up if you considered capability, opportunity, motivation, or all the 14 domains? So just have a go with playing with those two frameworks, or one of the two frameworks of your choosing, and we'll hopefully have some time for some quick feedback. So we'll give you 10, 15 minutes for that. Right. So how did that go? Does anybody want to share their experience of trying to apply or trying to use the TDF or the COM-B, or even better, to share some of their thoughts on the barriers that they thought might be relevant for the particular behavior that they identified? Is anybody? Yes, Mark.
I think our main struggle was, we went back to the diabetes one, and our main struggle, I think, was getting from the scenario, which we think probably has dozens and dozens of individual behaviours within it, down to, so what is it we're trying, who are we trying to change to do what? So we probably used about half the time just focusing down on one of those.
Right.
And the teasing out, I think.
Well, first of all, can you talk us through how you decided on it? Because that's something that we struggle with often, is how do you pin down the behavior? And sometimes we pin down to one, and often we say, well, it is more than one, and we need to go for more than one.
Well, we started off by thinking about, well, there probably are some things that are common across these. So there are a number of them that are about decisions about drugs, pharmacological interventions. So we grouped those together, but we decided, for the sake of convenience, probably more than anything, that it may be easier for us all to debate about the self-management side of things, that patient education, be more common currency, given that none of us are diabetes specialists. And our action was regular support of self-management of diabetes by practice nurses. That was
great.
That was where we ended up, and more or less how we got there.
Great. Yeah, excellent. Anybody else want to describe the behavior they chose and maybe start to think through some of the barriers that they link to particular domains, if you got that far? Or maybe some general points about just what did you think of using or trying to use the tool? Was it helpful in any way? Did you find it difficult? Was it not helpful at all? Did it miss the boat completely?
I have a question which is for clarification, I suppose, which is I was assuming that the framework works because you're asking the questions of the people you want to change their behaviour.
Yes.
Which meant doing the task actually quite difficult, I guess, like the other table was saying. So I think if that is the case, that's probably an important thing that needs to be stressed.
Yes.
And it made the exercise quite difficult.
Yeah, so it was indeed quite hypothetical and it sort of required some background knowledge, I definitely admit. But yeah.
But I mean, when we've used TDF, it's not with the assumption that the people we're interviewing want to change their behaviour. It's very much about what are the determinants of your behaviour. Well, yeah, these are the kind of issues, what influence whether you do them or not. So it's not. So we're kind of. I mean, and actually, you want people across the range. You know, if you only go for the keeners, then the problem is the keeners are probably different to the non-keeners. So yeah, we normally try and get a sort of broad range of views of settings where the behaviours may be used or may not be used, and look at those. So it's not necessarily looking for people who want to change.
No, but they're people who do the job.
Sorry?
But they are people who do the job.
Yes. There was down here.
We had two parts to our discussion, really. The first one was the really kind of interesting point about hand washing, that you need to work at different levels because it's about influencing individuals. But when you're trying to do this at scale, you also need to look at behaviours of people who need to support this within the organisation, and particularly organisational clinical leaders. Because quite often, people within organisations, they take their lead from the leaders, the people who they sort of perceive as leading change, etc., and the priorities they place on things. And it's absolutely fatal if you don't pay attention to making those people sort of live this and support it and advocate it and say it is a priority. Because otherwise people just ignore it and go off and do different things. So that's one level of the discussion.
Definitely. And I think, just to pick up, I think that whole advocating can be described as a behavior in itself. You could try to see do people have the intention to advocate this? Do they have the skills to advocate it? Do they have the interpersonal skills to advocate it? And describing that higher level social influence as a behavior that someone at a managerial level has to do would be a really nice application of the TDF, I think. Yeah.
The second level of the discussion was about the kind of practicalities, and I guess it's about the belief about consequences and motivation. Because a colleague cited a particular kind of environment where it's really nice kind of hand washing sort of solutions and things like that, nicely laid out, etc. Lots of reminders there and cues and stuff. It makes you want to wash your hands because it's actually a nice environment to be. Other places, it's horrible hand washing solution, particularly when you're having to use it sort of 20 times a day. There is no cues, etc. So they're the sort of things, again, that in terms of belief about consequences, the negative aspects, I think we need to kind of understand more fully in terms of why people wouldn't want to wash their hands. And if it's an unpleasant experience and have to be repeated constantly, that's an important issue.
Yes, and that almost dips into the emotion side of things as well. You can consider that as a kind of emotional response to the environment that you're in. And yeah, but picking up on the cues aspect too, just having, sometimes people become unaware. I mean, someone at the back, I think, made the point about certain things become just part of the fixtures on the walls or the wallpaper. And I think, but those cues do drive people's behavior. So if they're effective, then that in nice environments, then that may support the behavior change even better. Yeah.
So what we want to do before lunch is I'm going to describe what we found when we tried to identify potential barriers and facilitators to physician hand hygiene in my hospital using TDF. So the background is Ontario, the province I live, has an expectation that hospitals will have, I think it's 85 to 90% healthcare professional hand hygiene rates. And if you look at our hospital, we actually score at the aggregate level because our nurses and our respiratory therapists and physiotherapists are really good. But physicians have been one group that have been running around about 60% on an ongoing basis despite multiple issues. Actually, Kathy Sue is our local physician hand hygiene champion. And I was teaching on a course for her and going through some of this stuff, and she grabbed me at the end and said, we need to talk. And so what we did is we built a project where basically we wanted to see whether these behavioral approaches gave new insights into how to tackle what was seen as a fairly intransigent problem in the hospital. We did manage to get external funding for this, so it turned into being a bit more of a research project rather than a service development project. So we did more than you would necessarily do if you're just doing it in your local hospital. But what we were interested in doing is knowing whether physicians and surgeons had similar belief systems, and also whether consultants and trainees had similar belief systems. And we also are a hospital that works on 2 campuses, and we felt there were kind of different cultures on the different campuses. So we actually ended up doing a theoretical domains framework with 42 professionals, so really representing surgeons, physicians, consultants, junior doctors, and the different campuses. The other thing we also did was we did some observation on the wards. So one of the issues around the theoretical domains framework is it asks you about your perceptions about what influences your behavior. And we often are not necessarily very good at understanding those. So I think one of the things are, if you can find other data sources that either confirm or refute, is very helpful. So we just wanted to go and watch what was happening on the ward. And what I've got here is I'm just going to walk through some of the kind of beliefs that came up, and then later on we'll talk about how we turned that into a program. So this was the cane or the TDF. Show of hands, I mean, how many people thought that knowledge would be a barrier? Okay. Skills? Professional role and identity? Beliefs about capabilities? Optimism? Consequences? Okay, that's got quite a few nods. There's one person who says put their hand up for everything, so they're very pessimistic about this. Reinforcement? Intentions, goals, memory, attention, decision processes, yeah. Environmental context and resources, okay. Social influences, emotion, behavioral regulation. Okay, so I mean, what I got from the room is that people certainly thought that environmental context, memory, attention, decision processes, belief about consequences, were, probably had the most nodding of heads, but most people are saying, well, actually across these, there's quite a number. And what I've done here is just bold the areas that we found, and I'm going to go through them. So we didn't think that knowledge was going to be a major issue, and at the kind of general level, no one sort of said, no one has ever told me before I should wash my hands before I touch a patient. So it wasn't at that general level that there was a barrier there. But you probably have the same. We have the idea of 4 moments of hand hygiene. Before you go into the room with a patient, before you touch the patient or the patient environment, before an invasive, no, wait a second. Before you go into the room and the patient's environment, and before you do an invasive procedure, if you come into contact with any bodily fluids or secretions, and when you leave the room. Okay, those are our 4 moments of hand hygiene. And what the clinicians said was no one had actually really gone through that with them. There's kind of an assumption that by osmosis that they had got that. So it was one of those areas where it was kind of just wanting to reinforce potentially what was going on. In terms about beliefs about consequences that you thought might be important, some people thought it reduced the risk of transmission of infection, but others were sort of less sure. Yeah, they're kind of, I mean, we got into sort of statements of, well, you can't, no one can tell me if I don't wash my hand and touch that patient that they're going to get an infection, it's down to me. And so some of the issues were, and I think that was a kind of defensive reaction, Because I'm sure if it was their mother who was lying in the hospital bed and there's a surgeon who didn't wash their hands, that they'd be a bit irritated about that. But it was this kind of, it's almost a defensive mechanism. If I don't do this, you can't prove that that necessarily I'm doing harm. Beliefs about consequences, hand hygiene is easy to practice, but other people saying, I'm actually not sure. Certainly when I was a junior hospital doctor, I think when I was going into the operating room, I was taught how to wash my hands to go into the operating room. But I can't think of anyone ever saying just in the routine clinical setting what may or may not be appropriate behaviour. 25, 30 years on, more, you're probably doing okay, but maybe not. Social influence and patient expectations do or do not influence me to perform hand hygiene. If I see someone practicing hand hygiene, it influences me to do the same. One of the comments here from a junior hospital doctor was, if I'm rounding and every time the consultant goes into the patient's room and they wash their hands, it makes me think I should wash my hands. But actually, if I'm rounding and the consultant doesn't do that, then there's a kind of a message coming back that this isn't actually that important. Team culture influences others' hand hygiene practice. In goals, this is something that's always important, or it's not actually important. Patient emergency, someone's crashing, I'm not going to sort of stand and say, I want to wash my hands. I'm going to go in there. But there's clearly a gradation, and there's lots of times where we're actually very time pressured, where hand hygiene may not be the highest priority and is only one of the priorities I have to address. Skills, I do or do not consider hand hygiene a skill. I have or had not had training in hand hygiene. With repetition, hand hygiene practice becomes automatic. Okay? So, I think they're surfacing things that people said, but one of the issues I think that was helpful is actually just starting to think about, okay, here's a set of beliefs that people say are driving their behaviors. How can we actually start to address those? Memory, attention, decision processes. Hand hygiene is not an automatic process for me. When not touching the patient or the patient environment, hand hygiene is unnecessary. Now, this would be true according to the rules, but one of the key issues is, what is the patient's environment? And one of the people in the team said, I'd only accept that if someone went into the room like this. So it's like going into the room just to say, we've got your test results back and it's fine, but if you're leaning on the bed or you're looking at the charts, you're actually interacting with the patient's environment. There's a potential vector there. So again, a kind of a bit of an issue about sort of knowledge or awareness. Reminders might be useful. Easy, visible hand hygiene stations make it easier to remember hand hygiene. Social professional role. People did recognise this as potentially part of part of the patient consultations, etc. Environment. Easy access to hand hygiene stations makes it easier to practice hand hygiene. The location of the stations is important in facilitating hand hygiene practice. It takes time. When I'm busy, I'm less likely to comply with this. Okay? And then one of the things we did is, when we did the observation, what we found is that they're largely, I think, 1 or 2 bed wards or rooms. There are in general 3 alcohol dispensers around the room, but they're not in a consistent place in each room. So think about trying to have this as a habitual behaviour. And if I go in and I can do that as I'm walking to there, going there, and it's always there, it's straightforward. But if I go into the room and do that and it's not there, and I have to find somewhere else to go and do it, it becomes a very practical barrier. And if you're going to do anything that's going to ask a physician to spend 5 more seconds per patient, it's a big ask. There's also an issue that the alcohol dispensers are sometimes empty. And there wasn't clear in the ward we went into a clear view about what happens if they're empty, who's got responsibility for making sure they're in. So again, think about grounding. You go in and it's empty. And you go over here and do that grind. But by the 3rd bay you've gone to and you've got an empty hand hygiene dispenser, you kind of think, well, screw it, I'm not going to do this because it's taking me 10 seconds more per patient. The other thing is, the alcohol dispensers were a nice beige and the walls were a nice beige. So again, that idea about it's just not that obvious where they are. And when we presented this back to the team, their kind of heads sank because they thought they'd solved this. But I think someone earlier was sort of saying this is one of those areas where you just need a kind of constant attention to detail and constant sort of reminders to make sure it worked through. So when we did this, one of the things, I mean, as we presented this back to the team, so our team was a mixture of sort of the managers and physician and nurse hand hygiene champions in the hospital, as well as the research team. One of the comments was, there'd been a lot of initiatives that felt like they'd come down from above. And this was one of the first times that people felt that we were trying to engage the realities of the frontline staff and what they were facing, and they appreciated that as a kind of way of, instead of assuming we know what the problem is, actually trying to understand it from the people or from the target audience that we were working through. I mean, any kind of questions or comments about the hand hygiene thing while we're waiting for lunch to come in? Was there anything there that surprised you? Okay. If you went into your own institutions, I mean, how are your physician hand hygiene rates? So physicians say, so UK trained physician, I'm sure we're much better here. How are physician hand hygiene rates? Oh, you've been very quiet. Yeah, go on. They're similar.
You see differences in different professional groups and in different team cultures. I don't think it's much different.
Yeah. I mean, we found that there weren't major differences, say, between physicians and surgeons, or between the junior doctors and the consultants, beyond the kind of social influence of the consultants on the junior doctors. But when you looked at it, actually it's quite strong that these things were just sort of common sort of issues across these different groups and different sort of hospital settings, which in some way made our job easy, because when we came to think about an intervention, although we ended up doing things different between medicine and surgery for various reasons, it didn't mean that we were starting to try with so different issues between these different groups. Oh no, I don't think. I honestly can't tell you, but I don't think that it was particularly felt that surgeons were good and physicians were bad, or vice versa. I think probably the rates were kind of similar on both the sort of medical and surgical sides, around about 60-65%.
In terms of that culture, what was it in terms of your intervention? What do you think had the biggest impact on that?
So we'll talk about that in the afternoon. So we're going to sort of then say, okay, well, because we did this, and then you end up with sort of, okay, you surface a lot of beliefs. You still have to think, well, what are the interventions that might be useful? So as Justin said, one of the benefits of something like TDF is that there's a kind of an emerging body of knowledge that would say, well, if you want to change skills, here's the 4 or 5 things you should do if you want to change skills. If you want to change beliefs about consequences, this is what you should do over there. So we were left with what was a sort of a big menu of potential things we might want to target. We had to prioritize that. We had to think about practicalities. And I'll describe the kind of detailed intervention design after in one of the sessions later on.
A couple of comments, really. Sometimes it's worthwhile using the converse. When you're faced with the comment, where's the evidence that this works? I often would put it back and say, can you show me the evidence that rolling your sleeves up, tucking your tie in and washing your hands kills patients? And that can sometimes get through even the densest of surgeons. The other thing to say is that if people want something, they'll crawl over broken glass for it. Yes, there may not be gel in the bottles or in the baskets, but there's no reason why you can't have your own personal gel dispenser. It's a sort of, and I'm being slightly confused throughout this morning, because I've always held that you don't look for a technical solution to change behavior, you change attitudes. And many of the things here are about technical components, have the gel there, have it filled up, and so on and so forth. And I can understand why it's been done this way. But it's about hearts and minds, isn't it, really, on something like hand hygiene?
Well, so attitudes really is the beliefs about consequences.
Yeah.
And what TDF says is actually psychology will say there's lots of other things. So changing attitudes may be necessary, but it may not be sufficient if you have these other barriers at these other levels. So what I think the TDF is trying to say is we need to be aware of all of these things. And depending on what you find, you may have different challenges. So the kind of the sort of the non-participant observation that suggested that environmental context and resources was important was something that would say, well, actually, you need to think about changing maybe the physical environment responsibilities for filling up these baskets. But you do something different in terms of the beliefs about consequences, which is your example. So what I think when you do a TDF going in, you're largely sort of saying we're a bit agnostic. We're going to make sure we ask all these questions, and then it allows us to sort of really focus down on the areas that are important, and then we can think about what are the ways to try and address those areas. And it goes away from the idea of immediately jumping to either a solution or a problem, because it does sort of say, well, actually, I don't think emotion is going to be very important, but I'll at least ask a few questions about that. And when you do these interviews, you normally have kind of a high-level sort of question and a few probes. But you can clearly then probe down in more detail in those areas that are important, to try and make sense of it. So I think the benefit of this is it's reasonably comprehensive, bearing in mind the kind of or the slightly limited view around the memory, attention, decision-making process in external context. And you'll see that when we come to the solution we designed or we developed, it's not necessarily very technical. And it tried to use very practical resources around. But it's highlighting there's a range of determinants, and that then means there's a range of techniques that we can use to try and challenge them.